I'm Tim Suther. I'm with Change Healthcare. Welcome to Rise 2021. It's been an inspiring 2 days so far, and I can't wait to see what unfolds further. This is now my third decade in the business of data, analytics, and technology. I've been inspired by those as vehicles to improve the human condition and to create new economic value for all. And most of that has been in the business of advertising, technology, and financial services. But 5 years ago, I began to become increasingly alarmed by the trajectory of healthcare economics in this country and how it seemed to be disassociated from improvements in health outcomes. To put a fine point on that, we are now approaching $4 trillion in spend. That's about twice per capita any other developed country in the world. And for that, we rank number 43 in the world in life expectancy. So why is that? So 5 years ago, I was very, very curious about how could we take the lessons learned, the best practices that exist in advertising, technology, and financial services, two of the most advanced industries, in my opinion, using those tools. How could we take that and apply it to healthcare to improve health outcomes and health economics? I've increasingly focused on the relationship between what happens in the doctor's office or in the pharmacy with life outside it. And that relationship, it turns out to be key in terms of improving economics and outcomes. And my session this morning was really very focused on that particular topic. So it's pretty well socialized in our country that roughly 80% of our health outcomes are in some way influenced by the so-called social determinants of health. These are things like economic stability, that is whether or not you can afford healthcare, health literacy, your understanding of activities that improve or detract from your health, vulnerabilities in housing, in food, in transportation, your race and ethnicity, the language that you speak, the country that you emigrated from, and so many other factors. And understanding social determinants of health has been a challenge. So while 80% of outcomes are affected by social determinants of health, why is it then that so many of our programs that are social determinants oriented, why do they fail to deliver the results that we anticipate? And the talk that I gave this morning with Dr. Halamka focused on the lack of actionable information about patients. You see, many clinicians or their care management counterparts fail to have the necessary information about patients. So in an EMR, oftentimes that information is not available. If it is there, it's often non-standardized, meaning that two doctors can be referring to the same condition, but in different ways. Or sometimes the information is just simply based on geographic averages in your community. And that's helpful for planning activities, but it's not helpful for actually improving the life of an individual. You have to meet people where they are. So the session this morning focused really on the relationships between some of the most important social determinants of health as they related to healthcare utilization. We looked at economic stability, we looked at health literacy, and we looked at race and ethnicity. And the variations across each of those three are quite staggering. We also discussed how those disparities show up in a time of pandemic. And that's an area that we've spent a lot of time exploring. The raw reality is that as your economic instability increases, the more likely it is that you do not have the economic capacity to afford healthcare. The higher that is, the more likely that you will be diagnosed with COVID, the more likely it will be that you'll be hospitalized, end up in the ICU, and die. What isn't more likely is that you'll be vaccinated. And the combination of those factors is heartbreaking. And as a country, we need to do better. And our session here with RISE is inspiring in the sense that it is committed to doing something about that. We also looked at race and ethnicity. And there too is a very disturbing story. If your skin color is black or brown, you are more likely to get COVID, to be hospitalized, and to die. And that, ladies and gentlemen, is an unacceptable quality issue. We simply must do better. We explored how where you live makes a material difference in a health outcome. We displayed a heat map of various communities, and in many urban settings, the economic stability is naturally higher, and in rural areas, less so. But relying solely on a geographic representation of economic stability can also have misleading signals that you need to be attentive to. One of those is even in the most affluent communities here in the United States, you will typically find 10 to 20% of individuals in that community who are economically vulnerable. And by that, I mean borderline poverty level income. So if you're making decisions purely on the affluence of a community, and you are intending to use that to improve care for individuals, you are going to miss 10 to 20% of the individuals in the community. So a deep understanding of the individual, where they are in their economics, where they are in their patient journey, not just clinically, but in the lived life experience, is the secret to success. At Change Healthcare, we have the distinct privilege of working with many of the nation's leading academic medical researchers, and across therapeutic areas, across geography, across virtually every population cohort you can imagine, the truth is clear. Having a deeper understanding of what patients do or don't do when they're not in the doctor's office or in the pharmacies is a critical data point necessary if we are to improve the quality issues that are represented by health inequities in this country. A challenge that individual constituents will need to deal with is, as they gather information about social determinants and health equity, they will need to up their game in terms of data governance with particular regard to ethical use. It's really easy to have data that ends up not being representative, or data that inadvertently gets used in a way that was not intended. So having good monitoring systems are just essential to do this in the right way. A critical challenge for those committed to addressing health inequities is building trust. It's not lost on me, or I suspect on you, that there is a certain tenor that is associated with artificial intelligence. Namely that, hey, isn't artificial intelligence just instantiating all the biases that we have as humans? And there's some truth to that. However, there are steps that you can take to acknowledge that, to mitigate that, and to build trust. And that means having mathematical tests to ensure that your data is representative of the underlying population. It means that you should be back testing any algorithms to make sure that it doesn't have any inadvertent outcomes. And it means leveraging what, among other things, makes medicine strong. And that's the business of peer review. Going through a process of producing algorithms, giving it your best shot, and then putting it up to your peers to have them validate or contradict and improve the insights that you're recommending. So this is my first RISE. And I have to tell you, I was very, very inspired by the diversity of thought, of participation, just the tremendous ideas. And we should not take that for granted. That does not happen everywhere in healthcare. And it was a great privilege for me to experience it. And it is a wonderful aspect of Mayo for taking the time to focus on such an important issue in our healthcare. I'm inspired by the opportunity to better understand the lived life experience of our patients, to meet them where they are, to understand why they do what they do. And if we do that, we'll understand the friction points, the pitfalls in their patient journey. And if we understand those, we can do something about it and take steps to improve health outcomes for all in this country. And I'm so happy and delighted to be part of that with Mayo.